Now the thing is, the problem is that today's class is a continuation of what we discussed in the last class. Okay. So in the last class we had introduced the concept of screening and we had deliberated on what is the requirement of screening. And today we are going to talk about the screening tests. So those of you who did not attend the last class, it will be very difficult to follow this class. So what I am trying to do, what I will try to do is, I will try to first recap whatever we discussed in the last class in the initial 10 to 15 minutes, and then I will proceed to the contents of this class, okay. Even after that, it might so happen that since I am going fast to recap what we discussed in the last class, so some of that might not be comprehensible to you in that quick revision, okay. For them, I would suggest that yesterday only I have forwarded the link of that video to Nilanjan, okay. He must have shared it in your group also. So please find time to go through that in 2x also, but just go through that once, okay. So that then you will be able to understand whatever we will be discussing in today's class, okay. So as you know, the module that we are covering right now is screening for disease, okay, and that we will be covering over a period of 3 lectures, okay. The first one we discussed enumerating and evaluating the need of screening tests. Why do screening tests? Why at all go for screening, okay. Today's class we are supposed to discuss the properties of screening tests, namely sensitivity and specificity, isn't it, okay. So, okay, let me go quickly to recap. So what we have already discussed in the last class is that what is screening and to differentiate it from diagnostic testing, okay. We have discussed the concept of, we have understood screening from the concept of Iceberg Phenomenon of Disease. Next, we have enumerated the uses and types of screening tests. We have gone for the need of a screening program, when to do a screening, why do a screening, screening should be done for what kind of diseases, right. And then we have enumerated the common screening tests that we use in public health practice. We know that we have a public health program in our country, isn't it? There are various public health programs that run. Can you name some public health programs that run in our country? Just name the diseases for which we have public health programs. Yes, for malaria we have, the name of that program is National Vector-Borne Disease Control Program. In that we look after malaria, dengue, filaria, Kala-Azar, chikungunya, we look at all of those, isn't it? Then anything else? Tuberculosis, we have the National Tuberculosis Elimination Program. Anything else? Polio, we do not have a dedicated program for polio per se right now, but yes, we give vaccine for the polio under the National Immunization Program. Yes, so for antenatal care also we are looking at some specific diseases also, like maybe for neonatal tetanus, for sepsis during pregnancy, high risk pregnancies, but not really. ANC program is not really with respect to any disease, it is with respect to health in pregnancy, isn't it? Next we have the NP-NCD, the National Program for Non-Communicable Diseases, where we look at hypertension, diabetes, cancer, chronic obstructive pulmonary diseases and all of them, right. So for all of these programs, so whenever a program is devised, that program what it tries to do, it tries to find the burden of the disease in the community, okay. So all of these programs, they have to implement some screening tests in the community to understand what is the burden of the disease in the community, okay. So that is why we need to understand that what is the need of screening tests, when to do screening, what kind of screening test we should use, and what are the properties that will make us decide, okay, this screening test is a favorable screening test and this screening test is not, this test is not good to be used as a screening test, okay. That is mainly the crux of our discussion. So let me first quickly go through what we discussed in the last class. So in the last class we discussed the Iceberg Phenomenon of Disease. How many of you know the Iceberg Phenomenon of Disease? Quickly raise your hands. Have heard about it, know about this? No, few of you know, right? So what is Iceberg Phenomenon of Disease? Speaking very quickly, like when we go in the sea, if we are going to the high oceans in the south and in the north, then we will see that there are some floating icebergs. And we know in these floating icebergs, only a little part of those icebergs are floating. The large part of the icebergs are submerged. We cannot see them above the sea level, isn't it? Just like that, we think that every disease in the community, most of the diseases are like this, that only the people who feel sick, only the people who feel severely sick, they come to us. isn't it? They come to our hospitals, they come to our clinics, we perform some lab tests on them and we are able to detect them, isn't it? So only those at the tip of the iceberg who we can detect. But there are many people who have maybe subclinical symptoms, symptoms are not so severe, they do not come. There are many people who do not recognize that they have signs and symptoms, they have such a high pain threshold or such a high tolerance threshold that till they are severely ill, they will not seek care. So we miss them. There are many people who are sick but who never go to doctors. They do not have the opportunity, maybe the distance is too far, maybe it is expensive, they don't have the money, okay, maybe they do not have time. So due to that they do not come. So there is a huge burden of diseases which is undetected, that lies below the water level, okay. So Iceberg phenomenon of disease says that only a small part of the disease burden is diagnosed. The rest, bulk of the diseases, it remains below the water level and beyond our detection. So what do we want to do by screening? So who do we do screening upon? Those who were present in the last class? Who do we do it on? Do we do it on patients? Do we do it on the general population? We do it on the general population, isn't it? So screening we do on the general population. Why? Why do we do it on the general population? To find these submerged cases, the asymptomatic, pre-symptomatic, undiagnosed, latent or deliberately ignored cases. The cases who are not spontaneously coming to us, we want to detect them. For that, we do screening. So the objective of the screening program is to reduce, is to move the water level from here down to here. So as the water level comes down, what will happen? More and more of the cases will become detectable to us. We will be able to detect a wider margin of the burden of disease. Okay. So that is the objective of screening. That is the goal behind which, with which in mind we do screen, right. So going ahead, what was screening then? Screening is the presumptive identification. Okay, the word presumptive is very, very important. It is the presumptive identification of unrecognized disease or defect by the application of tests, examinations or other procedures which can be applied rapidly. Why so? Because see, the presumptive identification means by screening I will not label anyone as diseased. By screening my objective is to not label anyone as diseased. I will say that probably you have disease, you must come to the healthcare facility, we will do some confirmatory tests and then we will say whether you are diseased or not. But you could be diseased, you have a probability of having the disease. That is the objective of screening, to presumptive identification of the disease among those who are not coming to us but who are lying in the community with an underlying burden of the disease that we are not detecting otherwise. What is the problem? A, they could be suffering themselves and going to a severe level where we will not be able to cure them, or another problem could be if it is a communicable disease, then they will be transmitting the disease to other members of the community and the other members of the community are also not knowing that this person is diseased, so they will also not take any protection, isn't it? So that is the risk of having undiagnosed cases in the community. So with that objective, we will do presumptive identification of unrecognized, that person is still not realizing that they have disease. So of unrecognized disease or defect by the application of tests, procedures or examinations. They need not always be lab tests, they can be simple things like a BP measurement, isn't it? You know, in our national program for non-communicable disease, we have the guideline that every member in the community who is above 30 years of age must be having one BP measurement in 3 years time. Okay. So why? Because by that BP measurement we can detect whether there is an underlying burden of hypertension and we will be able to prevent severe cardiovascular diseases, we will be able to prevent strokes from occurring by detecting undiagnosed hypertension at an early stage. Okay. So the objective of the screening is to presumptive identification of unrecognized disease or defect by tests, procedures or examinations which can be performed rapidly. Now rapidity is a very essentiality of screening tests. Why? Because unlike a diagnostic test which we do for few people, only 1, 2, 3, 4, 10, 20 people who are coming to our healthcare facilities will do diagnostic test. But when it comes to a screening test, it has to be done for the general population. For large number of people, a screening test has to be done. Therefore, for it to be effective and for it to be scaled to the entire population, it is very, very essential that it can be administered rapidly, isn't it? So that is, so remember that the highlighted portions of the definition are things that you cannot forget when you are asked. Okay, you can change the other parts, but the highlighted portions in color must be there. Those are the 4 important things in the definition of screening test. Okay, do not forget them. So what we must remember is that it is applied to healthy individuals and it sorts out probably diseased from probably healthy. It is not a definite diagnosis. It is just a presumption. Okay, the screening test does a presumption, not a definite diagnosis. Is that clear to everyone? Any doubts, any questions? Okay. So it is not intended to be diagnostic. If a screening test is used like a diagnostic test, the consequences can be disastrous. You can label a healthy person as diseased. You can label a diseased person as healthy. So it is not intended to be diagnostic. Remember, always remember that. Now to be able to do a screening test, what is necessary is you need to have a detectable preclinical phase. Think of a disease, think of lightning strikes. Can you do screening? Road traffic accidents, can you do screening? No, they happen in a moment. The moment it strikes, the person suffers the consequences of the disease. So you do not get any time to screen. You need to have some time to screen. Suppose an infection occurs, from infection to overt disease, you need to have some time. For example, say with measles, I contract measles, I get infected, but from then to development of the rash, there will be 5 days, 4, 5 days, 6 days time. So in that time I can screen. Think of diabetes. If I develop diabetes at 40, then at 35 I am having dyslipidemia, I am having insulin resistance. At 30 I am having obesity, I am having a raised waist hip circumference. That is leading to diabetes at 40. So if I can screen at 30, at 32, at 35, at 37, then I can prevent diabetes from developing. So for us to be able to administer a screening test, it is very, very essential that there is a preclinical phase. That is between the onset of the disease and the overt development of the signs and symptoms, there must be a gap, isn't it? So next, there are some differences between screening and diagnostic tests. Quickly going, so screening test, it is applied to the general population. Diagnostic test, it is for symptomatic individuals or screen positives. The objective of the screening test is to sort out the likely infected or diseased from the general population. From the general population, we want to sort out the likely infected or diseased. Okay? And the objective of a diagnostic test is to establish disease in a patient. In establish disease in a person who is showing signs and symptoms or has sought care. Right? So if you remember, all of you have gone through the COVID pandemic, isn't it? You have some memory of the COVID pandemic. If you remember, in the COVID pandemic, the first test that was done was a rapid test. Any person who has any problem, they used to get a rapid test done. Once you had a rapid test done, after that only, we used to say that, okay, now if you are a rapid test positive, now you need to do a RT-PCR. Okay, the rapid test was a screening test. Okay, its objective was to detect whether there is any presumption of disease in the apparently healthy. Okay, you have just started to develop some non-specific signs and symptoms or no signs and symptoms. You have just had a contact with someone who is COVID positive. What do? You do a rapid test maybe after 5-7 days, isn't it? If the rapid test comes out positive, then you do a RT-PCR. So the RT-PCR was the diagnostic test. The rapid test was the screening test, isn't it? RT-PCR is looking exactly at the viral fragments of the COVID-19 DNA, isn't it? So RT-PCR cannot be wrong. It will always be correct, but then RT-PCR is expensive. RT-PCR is time taking. Rapid test can be done quickly, just by a swab at home. So it does not make the patient come out. In the process of coming out, that person can be exposed to many other people, can spread the disease to many other people. Okay, so a screening test must be applied rapidly, must be easy to administer. There are some characteristics, we will come to them. Okay, so these you will read. I have already discussed this in last class, I will not spend too much of time. So what is the objective of screening? The objective of screening, as I said in the first thing when we were discussing Iceberg phenomenon. First thing is there is a benefit to the person who is being screened. That is prescriptive screening. That if someone is having a disease which is unrecognized or undiagnosed, they might suffer severe consequences of the disease going forward. So the objective of prescriptive screening is to detect the disease early in that individual so that we are able to treat that patient, isn't it? And what is the objective of prospective screening? The objectives of the prospective screening is for benefits of others, for a contagious disease, for hepatitis, for HIV, for COVID. If we are not able to detect the undiagnosed cases in the community, then those people will be freely roaming in the community and they will be spreading the disease to others. So we were doing something like this with the Arogya Setu app, isn't it? It was telling you that okay, you have been in close vicinity or in contact with a person who is COVID-19 positive. So now you go and quarantine yourself for a few days and then you do a rapid test, isn't it? So this is the objective of a prospective screening. So one objective is for the benefit of the individual, the other objective is for the benefit of the community at large. Okay. The third objective is for collecting data. So we are having public health problems that we want to scale through our entire country. Now just like he said, for malaria we have a program. Now if we are supposed to have a program for malaria across this country, then what do we need? For malaria program ki lagbe amader? What do we need? What do we need? Suppose I am going to have a malaria program for the entire country. What do I need to have? What things do I need? I need some manpower, I need doctors, I need laboratory personnel, isn't it? Next, what do I need? I need testing kits, microscopes, isn't it? Then what do I need? I need drugs, medicines to be present across the country. So how do I decide as the national program person that how much of drugs, how much of lab kits, how many microscopes, how much doctors, how many lab personnel, at what density is required in which part of the country? How do I know? I know if I have population based data of that particular disease, isn't it? So that is another objective of doing screening, okay, to find out the burden of the disease in the community so that we are able to provide the adequate resources where they are required, isn't it? And finally, screening tests themselves provide an educational opportunity. What is the most common screening that is used for breast cancer? For breast cancer in the community, what is the most common screening that is used? It is self-breast examination. Self-breast examination. By the participant, she herself will examine her breast. So self-breast examination is the most common community-based screening tool that is used. Now suppose you go to a community and you say that we are going to teach you or we are going to screen you for breast cancer. For that, the screening test is self-breast examination. So first thing you have to teach them how to do self-breast examination, isn't it? You are going to talk about breast cancer. What are the signs, what are the symptoms, what happens, why people need to be aware. So the screening test itself serves as an educational opportunity to sensitize the community, to sensitize the population about the burden and the problem and the necessary precautions for that particular disease. Okay. So these are the broad purposes of screening. Okay. So types of screening program, I will not go into them, you will read them, I have already discussed it last class. Evaluation of the need. So when should we screen? This is the question that is very, very important. Should we screen just because we can? Should we screen for a disease just because we can? Should we or should we not? We have a screening test for a disease. Does that mean that we must screen for that disease? How many of you should think yes? Oh, the answer is already written. So we should not screen for a disease just because we have a test. Because a disease, after screening, there must be some benefit to the individual and or to the community and or to the government by doing that screening. Then only we will do that. Think of rabies. A dog bites, that person will take some prophylaxis. If they do not take that prophylaxis, they will develop rabies. If they develop rabies, we do not have any treatment. By detecting rabies early also, we cannot do anything. So is there any point of employing a screening test for rabies among those who have been bitten by a dog? No. So a disease must fit some criteria for us to take up that disease in our screening programs. We will not just screen for anything that we can screen. Think of prion mediated diseases. Okay, Kuru, Creutzfeldt-Jakob, mad cow disease. Okay, no treatment. More so, the incidence of those diseases in country like India is 0.085 per million. That means in 1 crore there will be 0.8 cases of that disease. So does it make sense to subject the entire population to screening tests for that particular disease which has such a less burden? So just because we have a screening test, we must not employ it. There are some criteria that the tests must fit, the disease must fit for us to be doing a screening program. So there are some criteria of the disease, there are some criteria of the test, and there are some criteria of the healthcare system. If all of these three are met, or all or most of these three are met, then only we go for the screening program. Okay. The name of this criteria is the Wilson-Jungner Criteria. It was provided by WHO in 1968. So we evaluate a disease in terms of some disease characteristics, some characteristics of the screening test available, and some characteristics of the healthcare system to decide whether we will be doing a screening or not. Okay. So what are the disease characteristics? As I said, so the disease must be an important public health problem. The disease must have a sufficiently high burden in terms of prevalence and in terms of severity of the disease. Not only prevalence, cough and cold also has a high prevalence. Does that mean we will go screening for cough and cold? No. So the disease must have a high prevalence and the disease must have a high burden in terms of morbidity and mortality that it causes. Okay. Then we will call it a public health problem and we will screen for the disease. Next, we already discussed this, the disease must have a detectable preclinical phase during which we will screen. Isn't it? We must have the time to screen for the disease. If there is no time, if the disease is very rapidly progressing, we cannot screen. So we must have some time. Next, the disease must have a understood natural history. We must understand how that disease progresses. Think of the initial days for COVID, the first 20, 30, 1 month, 2 months for COVID-19. We were not able to figure out only that okay, people are having this pneumonia, severe pneumonia, they are getting hospitalized. But we were not able to figure out that how do people contract this disease? How does it begin? What are the initial symptoms? What are the late symptoms? We were not able to do anything. So people in Italy, they were entirely confused. They said that why are you discriminating against the Chinese people? The disease, it has got nothing to do with them. And they started hugging. People coming from China, they started hugging, thinking that nothing will happen. Eventually, Italy had the earliest wave of COVID because we saw that COVID transmits by close proximity. So we must have a good knowledge of natural history of disease to be able to employ a good clinic screening program, right? So for the disease, there are 3 characteristics. It must be a public health problem, it must have a detectable preclinical phase, and it should have a understood natural history, isn't it? Next, there are some characteristics of the test. That is what we wanted to discuss today, but we must first cover this to be able to go there, isn't it? So, characteristics of the test. So, what are the characteristics of the test? First of all, the test must be valid. So, what is a valid test? Can anyone try to tell me what do you mean by validity of the test? I have written something, but what do you mean by validity of a test? You have heard of that story of Arjun, where he aims the bow and arrow and releases it and it hits the eye of the bird, isn't it? So if the screening test is able to hit the eye of the bird, then it is valid. So what is validity is basically accuracy, the ability of the test to give the correct result in accordance with the reality, isn't it? So if in reality if the person has a disease, the test must be able to say that okay, this is diseased. In reality if the person is not diseased, the test must be able to say it is not diseased. That is validity, ability of the test to give the correct result, accurate result, accuracy. What is reliability then? Now think, now if Arjun was instead asked to hit that bow and arrow 5 times. First time he got the eye, second time he gets the trunk of the tree, third time he gets one leaf, the leaf falls, fourth time he gets the tail of the bird, and fifth time he gets the body of the bird. Then Arjun was valid for the first time, but is Arjun reliable then? No, because on repeat exercises it is not giving the same result. So reliability is the ability of the test to give the same result on repeated administration. Okay, so a test has to be valid and reliable. Okay, that person had COVID, it detected COVID. That person then thought that no, I do not have COVID, did the test again, then it said negative. Problem, confusion. So it has to be reliable, it has to give the same result on repeated administration, isn't it? That is reliability. Can a test be not valid yet reliable? Can it be? Imagine Arjun with the bow and arrow. Arjun hits 5 times, each time he hits the same position in the trunk of the tree, but he misses the bird. But same point in the trunk of the tree he has hit. That means it is giving the consistent result, but the wrong consistent result. Okay. Then we have to calibrate. We have to calibrate. Hai na? Suppose a weight machine I am measuring, I know the weight of the person is 74 kilos. That weight machine is consistently giving 82. That means I have to recalibrate the weighing machine. It is giving consistent results, but it is displacing the result. है ना? Arjun को थोड़ा घुमा देना होगा. Then he'll hit the eye of the bird, isn't it? So that is validity and reliability. A test must be valid as well as reliable for it to be used as a screening test. Next, it has to be acceptable. It has to be acceptable to the community, it has to be acceptable to the individual. I cannot say that just because breast cancer is a problem, I will do biopsies on every individual. Will it be acceptable? It's painful, invasive, requires you to, have bandage and all of that for one day, might have a small scar. So it is not acceptable. So a screening test has to be acceptable. How will it be acceptable? It will be acceptable if it is not invasive. It will be acceptable if it is cheap. It will be acceptable if it is rapid, isn't it? It will be acceptable if it is not painful. So there are various things that the screening test must meet for it to be acceptable. So depending on the community, depending on the context, depending on the population in which we are going to implement the screening test, it has to be acceptable to that particular target population, isn't it? More importantly, it must be safe. It must be safe. The test itself must not lead to any harmful consequences. Okay, the test should not itself lead to any harmful consequences. Okay, I want to screen someone for lung cancer. For that I say that every year I will do a high resolution CT scan of thorax. लंग कैंसर खुद में नहीं होता तो HRCT हर साल करने से हो जाएगा by that radiation exposure, isn't it? So we will not recommend any screening test which itself is not safe if it is being done at regular intervals, isn't it? So the screening test has to be safe, it must be safe. We could have done for breast cancer, we could have said that we will get a CT done. We do not do because the radiation exposure is too high. So we will go for USG. We will go for mammogram, but not a CT for screening. If we get a lesion, then we can do other tests. But for screening, the test has to be safe. Okay. So the disease parameters were 3. Disease must be a public health problem. Disease must have a detectable preclinical phase, and the disease natural history must be known. For the test, there are 4 things. Test must be valid, test must be reliable, test must be acceptable, and it must be safe. Okay. So 3, 4, and then we have another 3 for the last, total 10 criteria we have. Okay. So we have discussed so we said disease, test and health system. So disease we have discussed, test we have discussed, health system is remaining. So test characteristics, disease characteristics done. So what are the characteristics of the health system? First and foremost, there must be an available treatment. I am detecting a lot of people, like I said, rabies. Suppose I develop a test that can identify rabies instantly after the dog bites. I do not have any treatment. That person would still have 4-5 days of healthy life. That also they won't have. In anxiety, they will start dying from that diagnosis day itself. So if I am diagnosing a disease early, by that diagnosis itself, we are giving them a burden of anxiety, a burden of sickness, a burden of depression, maybe a burden of a lot of mental trauma from a diagnosis. No diagnosis, no one says, okay, I've got a disease, I'm so happy. No one says, right? So the screening test will only do if we do have a treatment that we can implement after doing the screening, and if we can show that okay, treating this patient early will lead to better outcomes, isn't it? Administering the screening test must allow us to give a treatment early, and by applying that treatment early, we must be able to improve the prognosis of the patient, isn't it? The patient must have a better survival by virtue of that treatment. So there must be a acceptable treatment which is accepted and effective treatment. Untreatable disease, no point in screening, right? Next, we must have the adequate facilities for diagnosis and treatment. I have only one tertiary care hospital for maybe 2 crore population. Say, I have only one tertiary care government hospital for 2 crore population, and I am going and doing screening for cervical cancer. Now every day I am sending 30 screen positives to the tertiary care hospital. The tertiary care hospital does not have the ability to do so much of pap smear and the necessary colposcopic evaluation to get the definitive diagnosis or treatment. The tertiary care hospital maybe does not have a radiotherapy unit only. So what is the point of the screening then? Okay, so first of all, there must be a treatment, acceptable treatment that is available. Secondly, our healthcare system must have the ability to deal with the burden of diagnosis that we are going to give to it. Healthcare system was only looking at the tip of the iceberg. If the healthcare system also has to look at the submerged portion of the iceberg, the healthcare system must have the capacity to upscale itself. Otherwise, you are just going to give a lot of people a lot of anxiety who will not get any relief out of that, right? And then it has to be cost effective. I have done a screening test. The screening test is so expensive that the person's monthly savings is gone. Now they cannot go only for diagnostic or treatment, okay, or maybe the burden of the disease, the burden of the cost on the health system is too much. Like I said, I am spending crores of rupees by doing screening for a entire population, and I am detecting 10 cases, 30 cases, 40 cases. Not cost effective, not cost effective. So we have to look that okay, for this screening program, if I am implementing it on a population, what is my cost that I am giving, and then the effectiveness we calculate in terms of DALYs, disability adjusted life years. What is the burden of morbidity and mortality that it is reducing? What is the cost that it is taking, and what is the burden of morbidity and mortality that it is reducing? That we calculate in terms of DALYs. Read DALYs, it is very, very important. Okay, DALY is something that you must read. It's there in the 2nd chapter of PARC. Okay, read DALYs, it's very important. As an indicator, it is one of the only indicators which can measure morbidity and mortality both within it. So you can compare between a disease which causes only morbidity and a disease which causes only mortality by using DALYs. That's why it's a fantastic indicator. Okay, read DALYs. Okay. So then these are the 3 criteria of the healthcare system. So we know that now that there are 10 criteria by which we will decide whether to do screening for a particular disease. Of those 10 criteria, 3 characteristics are characteristics of the disease, 4 characteristics are characteristics of the test, and again 3 characteristics are characteristics of the healthcare system. Okay. Now healthcare system characteristics and disease characteristics can be widely different for different diseases. Okay. But screening test is something we must decide if we are going for a screening program. So today we will discuss what we wanted to originally discuss is the properties of the test, how to test for the validity of a screening test. That is what we wanted to discuss. Okay. So we will gradually start to do that and we will continue in the next class also. Okay. Is it helping the recap of the previous class? Because otherwise if I directly went into sensitivity specificity, nothing, you will not understand anything. Okay, and this is something you must understand, you cannot mark this up, you will forget every time you mark it up. Okay, column parameter, row parameter, you will forget. It's very volatile. Okay, so try and understand the concept behind it. Okay. So then, now word of caution, what are the harms of a screening test? What are the harms? First of all is overdiagnosis. There could be some diseases, maybe a very slow growing tumor. That tumor would never create any problem. A small fibroid of the uterus, it gets detected, and then you will be doing a total hysterectomy maybe for that fibroid. But maybe in that entire lifetime, that fibroid would have never caused any symptoms only. Okay. So there is this problem of overdiagnosis, of diagnosing diseases which might have been self-limiting or harmless, very slow progressing. We diagnose them and then we have to treat them. It causes a burden in terms of cost to the healthcare system also and to the patient also, in terms of loss of man days of work, some suffering in hospital and all of that. Okay. So that is one problem, overdiagnosis. Next is false positive. Suppose I am doing a screening test for HIV. Doing a screening test for HIV and I find few people who have tested positive in the screening test. Now there is a very over-enthusiastic lab technician who calls up those patients and tells them you have HIV. Then later on when we do the confirmatory test, we find that they do not have HIV, they were false positives. Now that is a huge problem. Think of how the world of a person changes for diseases like HIV which have a lot of stigma associated with them. We have very effective treatments right now, but still we cannot change people's minds. People still have a lot of stigma and discrimination when they get a diagnosis of HIV. Families fall apart. If it's a married family, the family can fall apart by such a diagnosis. Okay. So false positive in such scenarios can be having devastating consequences. Okay. So we must be very careful that a screening test gives a presumptive positive, not a confirmed positive. We must employ confirmatory tests before giving someone a diagnosis. A screening test is not for giving anyone a diagnosis. Okay, then we can avoid this harm of false positive. Next is false negatives. False negatives. Okay. False negatives means you think, suppose I am screening for, say you are screening for maybe acute myocardial infarction you are screening for. Okay, and you did the screening with a TROP-T test. Okay, there was some deficit in the TROP-T test, maybe it got expired or it is not a good quality kit, the TROP-T comes negative. You send that person home under the assumption that there is no myocardial infarction. That person suffers a cardiac arrest on the way to home. Very problematic. So false negatives are even more dangerous than false positives when it comes to screening tests. Why? Because false positive, if it comes, you still have the patient in the healthcare system. You can do the confirmatory test, rule out the disease, tell the patient nothing is wrong, you do not have the disease, go back, lead a healthy life. But false negative means the patient actually has the disease. I got an opportunity to screen. I still could not detect the disease. Instead, I have given the patient the message that you do not have the disease. So if the patient would have come back after 6 months, say with diabetes or with some cancer, if the patient would have come back with that 6 months, now they will come back after 3 years. Because you have done a test and you have labeled that you do not have disease. So for screening, false negatives are much more dangerous than false positives. Okay, so we are still okay with false positives because we tell them that this is not a diagnosis, this is just a presumption. We'll subject you to confirmatory tests. But false negatives are a strict no-no when it comes to screening tests. Is that clear with everyone? A screening test should not have false negatives. It can have some false positives. Okay? And then there can be some epidemiological biases, that is illusions that screening might create. Okay, this part we did not discuss in the last class also, so we will begin from the discussion of the epidemiological biases that arise out of screening tests. Okay. So what are the epidemiological biases? The first epidemiological bias is known as a lead time bias. So what is a lead time bias? It is the illusion of prolonged survival caused by detecting a disease earlier in its natural history without actually delaying death. What does this mean? Now suppose think of breast cancer, or say think of lung cancer. Think of lung cancer, okay? Or think of cervical cancer. Now cervical cancer maybe it gets diagnosed usually at this point when the person presents with maybe some abnormal uterine bleeding, or that person is presenting with some mid-cycle bleeding, or they are presenting with some post-menopausal bleeding, okay, and you are suspecting that okay, there could be cervical cancer. So usually it gets maybe diagnosed at this point. And once it gets diagnosed at this point, after treatment and everything, maybe people survive for 5 years. And then on an average maybe people survive for 5 years and then they die for cervical cancer. Think, okay, maybe this is the natural history of disease, how it is. Now you develop a screening test, okay. You develop a screening test which is able to detect cervical cancer somewhere here. This is the usual point of diagnosis. And then immediately you get the treatment. So after treatment, the survival, after survival, for cancers we calculate treatment by 5-year survival rate, isn't it? So after treatment, the 5-year survival rate is this, okay. Then by the screening test, you diagnose the disease somewhat early, over here. And once you diagnose the disease early, you will give the treatment here only. You will give the treatment here only. And by giving the treatment there, you find that now the survival period is 10 years. Now the survival period from the time of treatment is 10 years. Okay. So apparently you will feel that the screening program is a successful one because you have increased the period of survival following treatment by 5 years. But what you will miss is that you have preponed the diagnosis by 5 years. You have preponed the diagnosis by 5 years. So 5 years the patient would be leading an asymptomatic disease-free life. You have diagnosed early, that is why the survival has increased. Your early treatment has not actually led to increase in survival of the patient. This is known as lead time bias, where the increase in survival is only due to the postponement of the diagnosis. the increase in survival is only due to the preponement of the diagnosis. So the screening test will become beneficial only if after diagnosing and treating here, the patient survives till here. This will be the benefit of the screening program, not this. This will be the benefit of the screening program. But if this is not there, then just by this also I might falsely conclude that the screening test is a good one, when in actuality it is not a good one then. Because despite early diagnosis and treatment, I am not able to improve the survival of the patient. So I am only living under the illusion of extending the survival of the patient. In reality, it is not happening. Okay, this is known as lead time bias. So as you see, survival time is measured from the time of diagnosis to the time of death. Screening advances the time of diagnosis. This is known as the lead time. The advancement in the time of diagnosis from the usual point of diagnosis done by a screening test is known as the lead time. Okay. And even if the treatment is completely ineffective and the patient dies at the exact same age, dying at the exact same age, the survival appears long simply because they knew they had the disease for a longer period. So this is known as lead time bias. Is it clear to everyone what is lead time bias? Any questions? No, okay. Next is another bias known as length bias. These are the two biases, lead time bias and length bias. What is length bias? Length bias is, see, not all forms of the same disease are exactly same. The same viral illness, maybe say COVID-19, if you think of just COVID-19. Now COVID-19 had a beta variant, it had a Omicron variant, it had a alpha variant. Now all of the variants had different severity. In the second wave, most people died. The Omicron variant hardly killed anyone. Very less mortalities when it came to the third wave compared to the number of cases, isn't it? So the length bias is, think of it again for a cancer. There can be some less aggressive versions of a cancer, the ones which are, marker positive, which respond to chemotherapeutic drugs, and there are some very aggressive forms of cancer which have high mutations, high rates of, multiplication. So what it says is that if a disease is very aggressive or fast growing, then the detectable preclinical phase for that disease is very less. Then we will not be able to detect that disease only. So the screening program will only be able to detect the slow growing diseases and not the fast growing diseases. The fast growing diseases will be lost, and the screening program will detect only the less aggressive or the slow growing diseases which already have a better survival than the fast growing diseases. And because the screening test will identify only the slow growing or the better diseases, the outcomes will also be better with the screening program. So we will apparently feel that the screening program is very effective, but in reality it is detecting the less aggressive forms. So the prognosis with those less aggressive forms was already better, and that is leading us to feel that our screening program is working, and in reality it is not. Okay, so length bias talks about the length of the disease. If the length of the disease is very aggressive, then those are not detected by the screening program. If the length of the disease is slow, gradual, then those are detected by the screening program. If the same disease has those variants, then this length bias comes into being. Is that clear? So far so good? Okay. So unfortunately we could not go into what we had originally intended to discuss. These are some examples of screening tests. So I wanted to discuss these things: differentiate between the reliability and validity of a screening test, construct a 2x2 contingency table for evaluating a screening test, define and calculate sensitivity and specificity, and evaluate when to prioritize specificity over sensitivity. this part unfortunately we have discussed the first part, which is the differentiation between reliability and validity, okay, but the rest of the part we will continue it in the next class. So please, those of you who could understand something, do come to the class on next Tuesday, okay, next Wednesday, sorry, Wednesday. So next Wednesday we are going to cover this and we are going to finish this particular topic, okay. Without continuation it is very difficult to, you know, get these things, right. So what I am going to do is I am going to give this entire PPT, including what I am going to cover in the next class. I am going to give this entire PPT to you today itself, okay. So what I want you to do is, if you can, please go through the PPT, please go through the PPT once and the last class's video once, those of you who were not there in the last class, so that we can cover in the next class, because I can complete it in 5 minutes and go, but then it will not be of any benefit if you are not able to understand it, okay. Any questions?